Next, we'll talk about dementia and pathology of neurodegenerative diseases. In normal aging, mild decreases in cognition may cause occasional word-finding difficulty, slower processing, and difficulty multitasking. Importantly, these changes do not impair daily functioning. In contrast, dementia is an acquired syndrome where cognitive decline causes impaired daily functioning. People vary in baseline cognitive ability, so the diagnosis of dementia requires that individuals show a decreased functioning on both the population level relative to other people, as well as a decline from their own cognitive baseline and an impairment in their normal functioning. Mild cognitive impairment is in between normal healthy aging and dementia. It's a decline in cognition worse than normal aging, but without impairment of daily functioning yet. Mild cognitive impairment can portend the diagnosis of dementia in a few years and is sometimes called very mild dementia. When working up a dementia, it is extremely important to take a detailed history. You should catalog what cognitive domains are impaired. This often requires obtaining collateral information from family members, as patients may lack insight. Various dementias differ in phenotype, so finding a constellation of symptoms can point towards a cause. Detailed timelines are also very helpful. You should look for objective mental status changes, but also perform a thorough general exam to look for systemic diseases that may impair cognition. Neurologically, look for deficits that localize or point to a specific disease process. Finally, imaging and labs help look for common treatable causes of impaired cognition, like infections, metabolic and endocrine abnormalities, tumors, or normal pressure hydrocephalus. The Clinical Dementia Rating Scale is used to stage dementia. The CDR is a structured clinical interview and ranges from 0 for normal to 3 for severe. 0.5 is essentially mild cognitive impairment. CDR1 patients are impaired at work and have trouble with complex tasks. CDR2 patients are impaired at both work and home and are rarely able to be alone. By the time patients get to CDR stage 3, they require total care from caretakers such as family members or nursing staff, and their cognitive domains are globally impaired. There are a number of different types of dementia that we'll discuss. Alzheimer's disease is the most common cause, but it's also important to think about vascular dementia, Lewy body dementia, and frontotemporal dementia. There are other less common causes of dementia, such as multiple system atrophy, corticobasal degeneration, and progressive supranuclear palsy, which are considered to be Parkinson's plus syndromes. Another important reason for obtaining a good timeline of patient symptoms is to rule out a rapidly progressive dementia, which can be caused by other diseases such as Creutzfeldt-Jakob disease, normal pressure hydrocephalus, and some types of autoimmune encephalitis. By far the most common cause of dementia is Alzheimer's disease. The risk of Alzheimer's goes up with age and actually occurs in about 30% of patients who are 90 or older. Alzheimer's is rare in patients under 65. While Alzheimer's is generally sporadic, there are genetic factors that can contribute to the risk of developing the disease. The ApoE gene is polymorphic. Patients with the E4 allele have increased risk of developing sporadic Alzheimer's disease, while the E2 allele is protective. Mutations in the amyloid precursor protein, presenilin 1 or presenilin 2 genes can cause an autosomal dominant inheritance pattern for Alzheimer's disease and cause an early onset of disease. But overall, these are rare in comparison to sporadic. All patients with Down syndrome develop Alzheimer's disease around age 40. This is thought to be because the amyloid precursor protein gene is on chromosome 21. Poor education, hearing loss, social isolation, depression, physical inactivity, and vascular risk factors such as smoking can increase the risk of developing Alzheimer's. Clinically, Alzheimer's disease presents with a gradual onset progressive dementia with prominent short-term memory issues early on. As the disease progresses, patients may become disoriented, be poorly attentive, become lost, and show poor judgment and problem solving. Personality changes typically occur late in the disease. Two important pathologic features of Alzheimer's are amyloid plaques and tau neurofibrillary tangles. Amyloid plaques are extracellular aggregates of misfolded amyloid beta. It's unclear whether the plaques cause Alzheimer's, but they begin accumulating during the preclinical stage of the disease. Amyloid beta also accumulates in blood vessels in the brain. This is known as cerebral amyloid angiopathy. Cerebral amyloid angiopathy makes the vessels susceptible to bleeding and can cause lobar hemorrhages. Neurofibrillary tangles, in contrast, are intracellular aggregations of hyperphosphorylated tau. Interestingly, the burden of tau neurofibrillary tangles correlates better with clinical severity than amyloid plaque burden. Dementia is thought to occur from resulting neuronal dysfunction with decreased synaptic density. Here's an example of a brain at autopsy without Alzheimer's disease on the left, compared to a brain with Alzheimer's on the right. You can see prominent gross atrophy of the gyri with widening of the sulci between them. There tends to be preferential atrophy of the temporoparietal lobes, particularly early in the disease. The hippocampus is often affected. Here's an example of the histopathologic features of Alzheimer's on silver stain. This is an amyloid plaque made up of extracellular misfolded amyloid beta. And here is a neurofibrillary tangle located within neurons and made up of hyperphosphorylated tau. PET scan radiotracers can target either amyloid plaques or neurofibrillary tangles. You can also see changes in the levels of A-beta-42 and tau in the CSF in Alzheimer's disease. Microglia can become active in response to the extracellular amyloid plaques and form foam cells. This may contribute to the neuronal dysfunction and contribute to the evolution and appearance of amyloid plaques over time, including plaques eventually shriveling and burning out. No treatments for Alzheimer's are truly disease-modifying. Acetylcholinesterase inhibitors like donepezil, galantamine, and rivastigmine may produce some cognitive benefit during treatments through increasing acetylcholine availability in the cortex. However, they don't change the progression of the disease, including the decline in cognition over time. Side effects of cholinesterase inhibitors come from the increase in acetylcholine and include nausea, diarrhea, and bradycardia. Memantine, an NMDA receptor antagonist, is added on once Alzheimer's progresses to moderate to severe impairment. Besides drugs, it's also important to encourage physical and cognitive activity. Let's also review other common types of dementia. Vascular dementia is the second most common cause after Alzheimer's disease. Vascular dementia is dementia resulting from the loss of neurons from ischemic damage. Patients tend to be older and have long-standing vascular risk factors like hypertension, hypercholesterolemia, a history of smoking, or diabetes. They may have a history of strokes as evidenced by focal neurologic deficits or radiographic evidence such as large prior strokes, leukemia infarcts, or evidence of white matter changes. Clinically, vascular dementia tends to progress in a stepwise manner, with periods of abrupt progression followed by periods of clinical stability. Pathophysiologically, cognition declines as damage accumulates from small vessel disease, atherosclerosis, or embolic infarcts. Treatment of vascular dementia focus on secondary stroke prevention and risk factor management. We'll next talk about Lewy body dementia. Onset of Lewy body dementia is generally between the ages of 50 to 90, so it may occur at a younger age than Alzheimer's disease. Clinically, it presents with predominant fluctuations in alertness and cognition. Patients with Lewy body dementia may have detailed visual hallucinations. Importantly, use of dopamine blocking agents like antipsychotics can drastically worsen other symptoms of Lewy body dementia. Lewy body dementia exists on a spectrum with Parkinson's disease, and patients exhibit Parkinsonian symptoms including tremor. The tremor in Lewy body dementia is more likely to be bilateral, while in Parkinson's disease it is more prominent on one side. Patients with Lewy body dementia may have REM sleep behavior disorders as well. Other supportive clinical features include falls, syncope, and autonomic dysfunction. Lewy body dementia may sometimes be treated with acetylcholinesterase inhibitors or dopamine agonists for the Parkinsonian symptoms. Pathologically, Lewy body dementia manifests as intracellular aggregates of ubiquitin and alpha-synuclein. There usually is a clearing around the Lewy body. Frontotemporal dementia usually occurs in patients between 45 to 65 years old, so it can also occur in a younger age range than expected for Alzheimer's. The term frontotemporal dementia describes a syndrome with two subtypes. The more common is behavioral variant frontotemporal dementia, manifesting as behavioral changes such as disinhibition, compulsive behavior, apathy, and poor judgment. Frequently, these symptoms are initially thought to be due to a psychiatric disorder before frontotemporal dementia can be diagnosed. The less common type is primary progressive aphasia, presenting primarily as impairment in language. Both eventually progress to affect memory. Frontotemporal dementia can be caused by a variety of different proteins and mutations. Collectively, they all cause preferential atrophy of the frontal and temporal lobes, described pathologically as frontotemporal lobar degeneration. A bunch of different proteins can be involved in the pathogenesis, but it's most commonly due to tau or TDP-43. Historically, frontotemporal dementia was known as Pick's disease. However, this is now reserved for the specific form of frontotemporal lobar degeneration, where Pick bodies are seen. Pick bodies are made up of 3R tau aggregates inside of neurons. Therefore, Pick's disease is a type of frontotemporal dementia, but not all frontotemporal dementias are a form of Pick's disease. Treatment of FTD is limited to symptomatic therapies. Here on the left, we have our normal brain at autopsy, and on the right is a brain with frontotemporal dementia. Degeneration of the temporal lobes and frontal lobes with sparing of the primary motor cortex can be seen. Here are examples of Pick bodies made up of intracellular 3R tau aggregates. You can see that they appear distinct from the tau neurofibrillary tangles seen in Alzheimer's disease. In Pick's disease, you can also see Pick cells filled with neurofilaments. And here are examples of TDP-43 inclusion bodies staining for ubiquitin. Lastly, we'll discuss Creutzfeldt-Jakob disease. This is an important cause of rapidly progressive dementia. In sporadic CJD, onset is usually 50 to 70 years old. Variant CJD can occur in patients less than 40 years old. Clinically, patients present with rapidly progressive dementia may also show myoclonus when surprised and characteristic periodic EEG spikes. CJD can be diagnosed based upon clinical features plus supporting evidence like EEG, CSF analysis for 14-3 protein, or MRI changes like cortical ribboning. Diagnosis can also be made with the real-time quaking-induced conversion assay, where a CSF sample is incubated in shaking conditions to precipitate the causative prion protein. Biopsy is usually not required. Here are examples of cortical ribboning that are relatively specific for CJD. Sporadic CJD generally shows basal ganglia T2 and DWI hyperintensities. Variant CJD generally shows similar changes in the thalamus. CJD is caused by aggregation of a misfolded form of the prion protein PRP. This toxic accumulation causes atrophy and spongiform changes to the brain, so the brain parenchyma looks like Swiss cheese on histology. Unfortunately, since CJD is uniformly fatal, treatment is primarily symptomatic and palliative.